want to give you a little background into the culture of Wisconsin. A typical Friday night in the state of Wisconsin involves going out to a supper club for a fish fry. This starts out with at least a minimum of 2 cocktails, which are called old fashions, which are made with brandy or whiskey, sugar, and sour or sweet soda, and any kind of garnish you can possibly imagine that people want on there. From there, we go to our table, because the supper club is packed and you're at the bar for a long time. And there they would have usually a perch or a walleye fish fry, even better if it's deep batter, beer batter, that's even better. Then with that comes coleslaw, French fries, baked potato with sour cream and butter, and usually rye bread and butter. So that starts out the Friday night evening, and then the tables are packed, so you go back to the bar and have a nice little ice cream drink afterwards to top off your meal, a grasshopper or a brandy Alexander. And I'll be completely honest with you, that is really the mentality and where we're at in Wisconsin. It's going to take a lot of work to get us to ordering salmon and broccoli on a Friday night out. A little bit about ThedaCare too. A lot of people ask me, ThedaCare, where did you get this name from? So ThedaCare is named after the daughter of the founder of Kimberly Clark, and her name was Theda Clark. So that's how we came up with ThedaCare. Kimberly Clark was started in northeastern Wisconsin. That the headquarters was located there until 1985 when they moved to Dallas, but we still have a large presence of Kimberly Clark in the valley, so that's where the name Theda came from. Our mission is to improve the health of our communities and always set and deliver the highest amount of care. I included this graphic here because at the center there is a little bit of something new we're doing at ThedaCare. That is Lori, no relation to me, but Lori is our prototype customer. And everything we do now at ThedaCare brings Lori to the forefront. Every process we make, every kind of decision we make that affects customer care, it's not just customers now, it affects Lori. We've given a name and a face. Lori is a customer that has a moderate income. She's responsible for raising children in our healthcare system. She's also responsible for taking care of her adult parents who are aging. She has transitions in healthcare. They've made up a whole prototype of what Lori involves, so to try to really give a face to that customer. The things around there are what is expected from our employees. We want our employees to love their work, to be courageous and think outside the box, and another thing is to have a thirst for learning. Those are our 3 top things we're looking at this year for our employees, and we're really working on our employee engagement scores to make ThedaCare the top place for people who want to work in the healthcare field. It is our #1 diagnosis at ThedaCare. We have 40,000 patients with that diagnosis on their problem list. I want to tell you, did I go past? Yep. So WCHQ, I don't know if any of you have heard of this. This is the Wisconsin Collaborative for Healthcare Quality. This is who we report to. ThedaCare was one of the founding members of this organization. It's made up of anywhere, it's a little transient, but about 22 to 25 healthcare organizations. We work together monthly to develop our measures. We report to them. And at WCHQ.org, you can go out there and see how ThedaCare as an organization is doing on these measures, and now we are reporting down to the clinic level on how each clinic is doing. In the next year, we plan on that then putting it down to the provider level. So that makes people sweat a little bit when that gets put out there down to the provider level for everyone to see. WCHQ does a lot of learning meetings where we get together, we come together and we steal shamelessly from each other. We share ideas. It's really open and people are just really engaged, and this is where our leadership looks to make sure that our numbers are really well. We're usually looking to be in the top 90th percentile, which means they want us to be #1 or 2 on these WCHQ measures. And this is our measure for our hypertension population. So we look at 18 through 85 years of age. with the last blood pressure controlled to 140/90 during the 12-month measurement period. Here it shows our standings, how we look with a couple of our chronic diseases and where we rank, and then who in other locations near us or around us in the state of Wisconsin and how they are doing on their numbers. This is our little bit about our Pioneer ACO. We are a Pioneer ACO member. We are Bellin Health, ThedaCare Healthcare Partners. Bellin Health is located in Green Bay. So we combined to form this Pioneer ACO, and we've had very, very good luck, a lot of hard work, and we've had good progress working with this Bellin Healthcare Partners. But I will tell you, one of the issues with this is it's never easy when the government makes up measures for you to follow, because they aren't quite what they should be clinically sometimes, and we already have established measures out there, so we got to change things, and it's confusing to our staff. Our MAs, I can't tell you how many times people are like, now what is an ACO? I don't understand what this ACO population is. And we've met some feedback from our providers also that they don't like it that we give a little more, when we have to give a little more attention to a specific population. They want all patients, all payers to be looked at as the same. Our goals are less than 140/90. These are our system quality goals, are to be the 90th percentile and 20% improvement from year to year. We do have an ambulatory physicians pay for performance program. This is 10% of our providers' contracts. They are measured on 10 measures, of which a compensation committee and our senior leadership and our quality department work together to form these measures every year. We do have some watch indicators. As we do well in a measure, we'll move that to our watch. And as we see that decline, we can move that back the next year back onto our comp program. These kind of measures are our blood pressure. Diabetes is our number one focus at ThedaCare. We are looking at our A1C population greater than 9. That is where we have put pretty much a great amount of our attention on in the last 2 years. Starting with one of the planks from a measure up, pressure down, is the development of a hypertension registry. We were an early adopter of Epic. We've been on Epic for 11 years. There is a downfall to that, in that Epic is probably a little bit better now if you purchase it at this stage of the game than it is if you've been a long-time user, because you've really tweaked and worked your own little things into it, and it doesn't work quite as well. So we are not on Reporting Workbench, which is one of the reporting areas in Epic. We used a homegrown hypertension registry, and we have this for several chronic diseases, diabetes, CAD. We have a prevention in there too, in immunizations, mammography, cervical cancer, and then our colorectal cancer screening patients. Our worksheets are a list of patients with a diagnosis of hypertension who you can pull them by active or inactive. Active means that they have had two visits in the last 24 months, with one of those happening in the last 12 months. We can identify those that are overdue for a blood pressure, those that are not at goal. These worksheets are updated every 24 hours, so every night they're updated and are current. And these can be accessed right from their computers at their workstations. It is color-coded. You can see we've gone here to a chronic disease worksheet where it includes diabetes, CAD, hypertension, because that came from a request from our staff at our clinics, because they don't want to pull up just hypertension. They want to work them all when they have multiple chronic conditions happening. One thing it does pull in any blood pressure that's taken at any ThedaCare or clinic that they've been seen at, and same with the lab works, any ThedaCare lab that has happened, that they go to for their lab tests. ThedaCare is very deeply involved in the lean process, and we have standard work on pretty much everything that we do. So this is our standard work on how to run those chronic disease worksheets. This is posted out there. Sometimes we have staff at clinics who, they should be working these worksheets every month, and they get away from it. They can't remember. There's always this standard work that they can go back out to and follow, so they know exactly how to run those worksheets. And then, obviously, again, you run the worksheets, and then this is standard work on how to work those chronic disease worksheets. So everybody is on the same page, and everybody is doing things the same way. We have many, many ways of reporting results and rates at our organization. We this is called STATIT, and this is a part of our provider scorecard. This is color-coded, and these colors are in red, green, and yellow, which obviously the red is kind of pink in here, but those are the lower scores, and the green are the higher scores. So anybody can access this in our organization, and this also can be broken down to the provider level versus just at the clinics. And on the top lists our comp measures for the year, so you know exactly how you're doing on each of the measures, the target, and then the current goal. Monthly rates reports, everything is, we changed a little bit on this from our providers this year. This one's a little confusing, but let's look at this one. Our compensation is tiered for our providers. So we have a green, yellow, blue, and gold. If they hit target, it's green. And then within 3%, it's blue, and then another 5%, 7%. So that came from our providers who felt like they still deserve compensation, even though they did not exactly hit target for every one of their patients. So now we've developed these rates for them because they wanted to know how they were doing, and they wanted to know how many numbers to goal. So that was added to these this year. How am I doing, and how many patients do I need to get in to get their blood pressure regulated before I'm reaching that goal? Obviously, like if you look at this one in the red, this provider has 0 points here. They need only 5 to get to goal. So they have a very small practice and a small patient panel, which also is not always easy to deal with. We have developed a new clinic patient care delivery model. This is what it was developed to talk about, deal with all aspects of our delivery model. We have standard work, we repeat our blood pressures, we use our health maintenance in Epic, and we also record the problem list or our goals on our problem list in Epic. So each one of those, and that is the responsibility of the provider to make sure that that problem list has the goals listed after that, for example, for blood pressure and A1C. Chart scrubbing is done every day before that patient comes in before their appointment, and then there is lists in Epic what they're missing and what they need to be addressed that day that they come in then. Here you will see our standard work. This is just a high-level view of our rooming standards. We made some changes to this year and have gone completely changed. If you will look through this at the top layer, obtaining height and weight, the next step was to get the patient's vitals. So we have moved patient vitals down to near to the end of the visit, try to develop a little rapport with the patient, relax them a little bit, kind of get them where they're sitting correctly, feet on the floor, arm resting. Just, we found a little bit better result from that than there was right away. They're coming in, they're a little bit nervous, and we're right away taking their height and weight, which doesn't make them happy, and then we're going right into their blood pressure. So kind of let them forget about that height and weight a little bit, and as we work down the whole process. And then our checkout process, we worked a lot on this year with our after-visit summary, which is printed directly out of Epic. And each patient receives this. This is our goal, and this is audited, so every patient is to get this after-visit summary when they leave our clinic. Our after-visit summary, this lists for patients who do not have blood pressure listed on their problem list. This is a part of their after-visit summary, on every after-visit summary. It prints out automatically, just understanding and talking about blood pressure, getting it out there for those patients who still have their blood pressures within the normal range. And then for patients who do have blood pressure listed on their problem list, we have this where it lists their blood pressure was today, it lists what their goals are, and then it also defines what their labs are, which pertain to their blood pressure, and lists that out there too for just give them this to take home with them. We just added a few little tips at the bottom so that when they are at home taking those home blood pressures, they're doing it the same way that you're taking it while you're doing it in the office. You know, it's really important, especially about drinking that coffee, smoking, you know, putting their arms resting. It's amazing how many, you know, will come in, especially in Wisconsin, with a lot of clothes on underneath, and will take the blood pressures with, you know, right on top of all that. We have a lot of tools in place for our staff to use. We have population grids, which are on the internet. They can just go right to there and know, now how do I figure out who's in my population and what makes this up? So this is a tool that our providers have requested, so they know exactly across the board who we report this to, what is this one of my compensation measures. This is a tracking center that is at each clinic site, and this is where staff Gemba every morning, and Gemba is a term for going to the work. So this is where they meet every morning, take a look at how things are going, things they need to work on. They'll also talk about the patients that they have coming in for the day and say, we got 5 patients who are coming in today who need a pneumococcal vaccine. Let's make sure we get that done today. Let's stay on top of this. And they'll do this sometimes and in the morning, and almost always at noon again for their afternoon patients that are coming in. This is our blood pressure competency. You can see here, we do train all our medical assistants in blood pressure competency, and then this is done yearly, and then they do have to have this filled out afterwards, so they have a minimum of 5 blood pressures that they've recorded that somebody has observed that they've done correctly. We were a champion for Million Hearts this year from our work that we've done, which was a great achievement for our organization, and we did receive a cash prize from them, which we did put into our blood pressure, some educational tools, and doing some marketing on having your blood pressure done. Summary on why this works. So leadership support. Our top leaders in our organization completely support the work and are always out there talking about the work. Standard work, repeating the blood pressures, yearly competencies, and those health maintenance, which are expected by the MAs who room those patients every single time. This is your work, this is the way it should be done every single time you do it. Problem list with goals, which has really helped a lot, especially for those MAs who weren't really sure on what's this patient's goal. How do I know that we weren't at what we should be? Those huddles, and then working the worksheets, and then our goals for internal pay for performance for our providers, and also that 90th percentile system quality goal is some of the things that really have made a difference, we feel, in our success. Thank you very much.
Two buttons go back and forth and just push the middle button.
Okay.
Thank you, everyone. I'm Betty Sedler with Colorado Springs Health Partners. I suddenly realized I'm the last speaker before lunch, so I'll try to get through this very quickly. Briefly, this is an outline of what I'd like to talk to you about today. Colorado Springs is located in beautiful Colorado. Colorado Springs is the center of the state of Colorado. We're at the foot of Pikes Peak, home of the Olympic Training Center, and Garden of the Gods, and one of the states with legalized marijuana. This slide needs to be changed today because many of you have seen the press release that went out yesterday. We are in the process of now becoming part of the DaVita Healthcare Partners system. We are a very small medical group currently. We have 11 practice sites amongst the Pikes Peak region, and we have same challenges that you all do. Let's cut to the chase. The reason I was invited to come and speak with you is that we had some dramatic improvement in our blood pressure management. We set our baseline in 2012, and we had less than 68% of our population that was in control. At the last measurement that you can see here at the end of August, we are now just below that 80%. So how did we get there? We identified what we called critical factors for success, and I'll go over each of these in more detail, but briefly: provider, staff, patient engagement, data transparency, and the all-important initiatives. As Lori alluded to, we felt that training, retraining the staff, the MA staff, in correct blood pressure measurement was very important. We set up a program that each of the MAs were just basically brought into a lunch and learn session, and instead of handing out a document that showed them the correct way to take blood pressure, we set them up into groups. Somebody was a patient, somebody was the MA rooming the patient, and they critiqued each other on how to take blood pressure. We also had a handout that we gave them from Kaiser, and I recognize our friends at Kaiser, that basically instructed them on the correct blood pressure measurement techniques, as well as the impact of incorrect blood pressure measurements. These are all posted in our vitals areas, as well as they're available in the provider toolkits on the Measure Up, Pressure Down campaign. Again, we did train all of our staff in the importance of blood pressure, as well as we obtained marketing materials from the Measure Up, Pressure Down campaign. This is a really hard plank to get buy-in to, the specialists, as Jerry alluded to. We had a few specialties that, frankly, they were more concerned with what they were looking at, namely dermatology, orthopedics. What does blood pressure mean to them? The fact that it was a measure of meaningful use criteria helped a little bit, but it took some arm wrestling, arm twisting from our CMO to try to get them to buy into this process. So as primary care physicians, and the primary care physicians developed some protocols to assist the specialists in referrals back to them. So what required an immediate phone call back to the primary care physician to get back in to see that PCP for their blood pressure, or what was more routine. Then the patient engagement we felt was very, very important as well. You can't start an outreach campaign without letting the patient know why we're calling them, why are we harassing them, in other words. We had an active outreach process that I'll go into a little bit more detail, but we also had a project with an organization, a new development software company in our area called Nomus, that was an engagement tool that basically sent a text to the patient to say, have you taken your blood pressure today? So the patient would enter their blood pressure reading, and if they didn't enter that blood pressure reading, then it sent them another reminder. If that blood pressure reading was over the guidelines that we set up individually, it sent them a reminder that said, did you take your blood pressure medication today? And if it came back that said yes, and if it was over a certain threshold, it would say, please call your primary care physician at X number. And it would send an alert to the PCP office to get in touch with that patient, to get them in for another visit or find out what was going on. As John mentioned, and as my colleagues have all mentioned, the registry is a very important plank that we felt. This is part of our data transparency culture. Through the use of Humedica Optum One, we have developed our registry system, and typically the registry out of our EMR, Allscripts, is not the greatest in the world. So we utilized Humedica to do this. So we give the registry to everybody and have an active outreach process. So again, like I said, data transparency is the most important thing that we think is important. We have started a data transparency culture from the beginning. We unblind all of our reports that we send to everybody. They're posted in all the offices. And we created an individual physician packet that myself and my director go out to each physician to personally deliver that packet. So what's in the packet? And I'll go over all these things in a little bit more detail. This is the cover sheet, and we made it bright and bold so that it wouldn't get lost on the physician's desk. This is a sample graph of one of our physicians who basically started out in the bottom of the cellar. And through this whole process, at the end of the measurement period, he went from worst to first. This is a comparison of the physicians at a particular practice location, showing how they are doing amongst their own practice location. This is a comparison of all of our practice locations. Since we started this whole process, we've now raised the bar. We set a goal of 80% as the measure up, pressure down, but now we've increased it to 82% to try to get us a little bit more cushion. And then finally, this is a roll-up of all of our physicians within our organization as how they're doing amongst all of their peers. And again, this is in each individual physician's packet, so they can see everybody how they're doing. This is a copy of our work list that we have produced from Humedica that basically gives the patient information and what their last blood pressure reading was and the date of that last blood pressure. So this allows the practice location to make their active outreach calls to the patient to say, hey, it's been a while since you've been in, or maybe we need to tweak your medication. Let's come in, let's get another blood pressure reading. As in a lot of the clinics, and we actually borrowed this from Brown and Tolan at their San Francisco office for medical home. And we have posted in all of our break areas, both the physician and the staff lounges, a poster that basically shows all of our quality metrics. And it shows not only the physicians at their location, but how that site is comparing to each other. So it produces and creates a friendly competition not only amongst the physicians, but a friendly competition amongst the staff. The MAs want their doc to be the best, basically. The incentives. While not the most important feature, it does help. We tied a small percentage of the physician compensation to quality measures. And they basically have kind of promoted the physicians to kind of say, take another look at what their measures are instead of just completely ignoring it. The group decided what the reasonable target would be, and we have frequent assistance for those docs that aren't meeting those measures. So we've come up with some top 10 lessons learned, and believe me, we're still learning. First, number 10 is show me the data. Our physicians were hungry for the data. And we couldn't produce it until we got the Humedica model. We centralized our data analytic department within my department so that we could dose out the data that we were providing so that they didn't get overload. We built our clinical infrastructure based on medical home concepts. We are NCQA patient-centered medical home level 3 certified in all of our primary care locations, and that did help. Again, engaging the patient so that they understand why we're reaching out to them, and clearly identifying that target goal. Actually, let me go back to that one. Using Humedica and being part of the ANSETA collaborative gives us benchmarks that are nationwide rather than just internal. So that was clearly important to our physicians. Again, the financial incentive was important, and creating that data transparency culture so that everybody knows where they're at to start with. And then starting on a small focus campaign, just like Measure Up, Pressure Down, with certain steps and guidelines to go by, was a very key. And then recognizing data is never perfect. Everybody's going to question your data, so the enemy of good is perfect. And finally, this is hard work, so take your baby steps and celebrate your successes. Thank you very much.
So actually, please join me in thanking all of our 3 medical groups and their wonderful presentations. We have about 6 minutes left for questions, so if someone has a question, please raise your hand. So let's get a microphone over there. And please maybe state if it's for everyone or someone specific. I think it's coming to you.
Yeah, so my name's Jeff Klingman. I actually work for Kaiser Permanente in Northern California, but I would also like to welcome everyone here to Berkeley and Alameda County, where we are in the beginning phases of an initiative to improve blood pressure control for all 1.5 million people. My question is about this Humedica thing, because one of the challenges is we're starting to think about this early on relates to data. Many of the folks that are in the different disparate medical groups have EMRs. Many of them are not the same EMRs. Most of the EMRs don't talk to each other. We do have a smattering of folks that take care of high-risk folks that, sort of solo practitioners that are kind of holding on by their fingernails that don't have EMRs. But the first step of this, obviously, is how you can get some registry put together, some data to know where you're at. And I'm wondering, it sounds like this is a tool that works across different EMRs.
John?
Yes, it does. It is a population health analytics tool, and it's one of several alternatives on the market, but Humedica's emphasis has been actually getting the clinical data at the level of detail you've seen and mapping it and normalizing it so people can actually do apples-to-apples comparisons. But yes, it's a commercial product, and they have an improving process for implementation. This is, it's always hard to do the implementation. And one of the things Humedica has discovered as part of this, and we've tried a couple of other approaches first, but the fact that they actually go extract the data from the EHRs rather than relying on the groups to do their own extraction and mapping and sending it in is a huge component of being successful in that business.
I think there's a question over here. Yeah.
Hi, Neil Kohatz. I'm the medical director at Department of Healthcare Services, and in patient safety and in quality in general, people talk about creating a culture of quality. I wonder, it's really for all the panelists to talk about creating that culture at the system-wide level versus the individual practices. We had 11 clinic sites, 20 clinic sites, 5 hospitals, that kind of thing.
Who wants to go first?
What we have at DataCare is what's called True North metrics, which is really how we're driven throughout the year. Those are really visible to all our staff, and quality is part of that triangle of True North: safety, quality, and patient. So I think it's really well communicated to our staff, and across the organization, everyone will be able to tell you what our True North metrics are.
I mean, same, at Sharp.